in which this instruction course is mainly about the most of the cases of efferent visual pathway and some are from afferent visual pathway, and main emphasis is given that proper clinical examination is must before asking for any diagnostic investigation, because it still keeps a very important role in so much of advanced diagnostic modalities are available. And we will finally, the neuroimaging, which is a very important part of neuro-ophthalmology, we would be discussing. It's mainly a case-based discussion, so I hope it might be interesting. So the first, I would be presenting my cases of, again, Kumudini Sharma. हो गया इसको ऑन करो इस पर नहीं आ रहा last one. Okay. So I would be presenting some of the cases. Excuse me. भैया इसको जरा फुल स्क्रीन पे कर दीजिए. ओके आ गया. ठीक है थैंक यू. इसको फुल स्क्रीन पे कर दो. फुल स्क्रीन कर रहे हैं. हाँ जी. So I would be presenting some of the cases which are not a very common presentation, and so they would be mainly infranuclear. And first case is about a 22-year-old female. She presented with drooping of the left eyelid. Prior to this presentation, a week back, she had a fever with rigor, horocrinial headache, which was quite intractable. And she had a marked pain in the neck, which was increasing on neck bending. She was very photophobic, and she, along with all these features, she had upper respiratory tract infection. So all these symptoms, they are very much suggestive of viral meningitis. And we know viral meningitis is a very self-limiting, has a self-limiting course. So when she came to us, when we examined her acuity was normal, the ocular motif was very much suggestive of left third nerve palsy, she had a left third nerve palsy, while rest of the cranial nerve, neuro-ophthalmic examination, ocular examination, and neurological examination was normal. So we made a diagnosis of post-viral left third nerve palsy, and blood tests were normal. But still, as a viral meningitis, following that the nerve palsy is not very common, so we got the neuroimaging done to rule out any structural cause for that. So what we found, there was a thickening and enhancement of the third nerve, as pointed out by the arrow, in the subarachnoid part of its course. And this enhancement of third nerve in the subarachnoid course on MRI is seen in ischemic insult to the nerve, or inflammation or infection of the nerve by bacterial and fungal meningitis. The most common cranial nerves are involved in bacterial and fungal meningitis because a lot of exudations are there. Basal exudations are there in these type of meningitis, while in the viral, it's a very minimal CSF changes are there. And any neoplastic change of the neoplastic cause of the third nerve, like schwannoma, is very much common, which can present as a cryptic third nerve palsy and ophthalmoplegic migraine. Now this term of ophthalmoplegic migraine is changed into the recurrent painful ophthalmoplegic neuropathy, because these patients do not have a very classical headache or a pain like a migraine. So these are the common causes of enhancement of the subarachnoid part of the third nerve on MRI. In our case, it was the inflammation of the third nerve, the post-viral demyelination of the third nerve that was responsible for disruption of the blood-brain barrier and enhancement of the nerve. We gave the steroid to the patient, and after the end of 1 month or 1.5 months, the patient third nerve resolved completely. So this is the inflammation of the subarachnoid part of the third nerve following the viral meningitis, which we all know it has a self-limiting course. So this case, we learned that a detailed history about the preceding symptoms is important to help to make a proper diagnosis of this condition. The common causes of third nerve palsy of the involvement of the subarachnoid part in this young patients are commonly is the microvascular ischemia, not because of a vasculopathic cause, it's mainly the vasculitis. Second, the meningitis and the tumor of the nerve itself, a schwannoma, or when there is a supratentorial tumor or a hemorrhage which causes tentorial herniation and trauma. These are the main common causes, but there is a long list of causes, but these are the main common causes of third nerve palsy in the young person which we come across in our practice. The second is again a young patient who presented with painless third nerve palsy of acute onset. And this patient, when we asked her whether she has any associated symptoms besides this third nerve palsy, besides the drooping of the lid, she admitted that she had a mild pain in both the limbs with mild swelling, and she had generalized body ache for last 1 month. The visual acuity examination was normal, and there was a right third nerve palsy which was complete, involving the pupil also. Rest of the neurological examination and neuro-ophthalmologic ocular examination was normal. Since she was a young patient with acute onset of third nerve palsy, which we know below the age of 50 years is a vasculitis, which is a common cause of third nerve palsy, and after the age of 50 years a vasculopathic cause like diabetes, hypertension. Since we thought it might be a vasculitis, as she had a systemic symptoms also, we got the complete blood hemogram done. We found the inflammatory markers were raised, and we also asked for vasculitis, as it's a common cause of third nerve palsy in this age group. And we found out that all autoantibodies were raised with a decrease in the complement level. But the rest of the investigation like chemistry and the CT was normal. We thought it's because of the vasculitis. We referred the patient to immunology department, where the diagnosis of SLE was made, and she was given methylprednisolone. Even on the 4th day of the methylprednisolone, there was a marked improvement in her third nerve palsy. So this is a young patient in whom the third nerve palsy is a presenting sign of SLE. So third nerve involvement in SLE is due to damage of the endothelium or the vasa nervosa by the circulating antigen antibody complexes, or there would be a microthrombosis. As we know, these patients are having a increased antiphospholipid antibody. So it's a kind of a ischemic third nerve palsy. So in a young patient with third nerve palsy who had a systemic symptoms, we should ask any associated symptoms are there or not. So the systemic symptom, a workup for autoimmune disease to rule out vasculitis as cause should be done. Now this third patient is about a 50-year-old patient who presented with sudden onset of vertical diplopia, but at the time of diplopia he had mild uneasiness in the head, and all these symptoms appeared when he was kicking his scooter. He was a known hypertensive, but the other systemic diseases were not there. The visual acuity was normal. The ocular motility was suggestive of left fourth nerve palsy. The rest of the ocular neuro-ophthalmic neurological examination was normal. And as we know, the fourth nerve palsy, the most common cause is trauma. The history of trauma was not there. Second most common cause is congenital one. But he didn't have any head posture, head tilt, and there was no increase in the vertical fusional amplitude. And we thought there might be some structural cause, because when the patient had an onset of diplopia, he had some mild uneasiness in the head, and he was kicking. That's why he was increasing. Doing a little bit of a raised pressure must be there because he was kicking. So we got the MRI done to rule out any structural cause, as the trauma and congenitis were ruled out. What we found out, there was a dilated vein in the left ambient cistern, as you can see at the MRI. And though these vessels must be there for a long time, and if you correlate the imaging with the neuroanatomy of this site, you can find out the fourth nerve is the one which comes out from the dorsal surface of the midbrain below the inferior colliculus. Then it winds around the cerebellar peduncles. And this course, it lies in the perimesencephalic, or what we call ambient cistern. And the location of our lesion is also at the same site, explaining the involvement of the fourth nerve. But these blood vessels would be there, they are soft, usually doesn't cause any compression. Why there is a palsy in this patient? The most probably, as he kicked, increases the intra-abdominal pressure, or these vessels are the very weak vessels. And DSA was done, and it ruled out a dural AVM in the left ambient cistern. There were no indication of subarachnoid hemorrhage in this patient. So the fourth nib palsy in this patient due to a perimesencephalic dural AVM might be because of a blood. These blood vessels must have bled in the substance, the fourth nerve, causing dysfunction of this fourth nerve activity. So while you see any patient with oculomotor disorder, take a proper history. That was the symptom of uneasiness at the time of diplopia led us to do neuroimaging. Otherwise, he was a hypertensive adult. We might have thought it is a vasculopathic cause. Vasculopathy is a more common cause of third, and next is the sixth. Fourth come last in the list. So the additional symptom of uneasiness made us to do the neuroimaging, and we ruled out this pathology, and we referred the patient to neuroradiological intervention. This patient we had was operated by a neurosurgeon for the trigeminal neuralgia, trigeminal schwannoma. Following the neurosurgical operation, he developed left-sided sixth and mild seventh nerve palsy. So he had a double vision because of sixth nerve palsy, but he had marked burning and foreign body sensation in the left eye. These symptoms were there not before the surgery. So the visual acuity was normal. He had a left esotropia as the sixth nerve was involved, and corneal sensation were diminished, but they were better what he had before the surgery. So there was improvement in the sensation of the trigeminal nerve distribution. But the cornea was lustreless, and there was not much seventh nerve palsy. As you can see, the patient can shut his eyes properly. But the Sharma test showed a very poor reading on the left side. Anyone can suggest me what could be the cause of this dryness in this eye? Okay, the cause of dryness in this patient was, which was causing the burning and foreign body sensation to this patient, though his seventh was not that much involved, he would have leg of thalamus, and the fifth sensation have come back, and these symptoms were not there before the surgery. So the things have developed after the surgery. So it was a seventh nerve involvement. As you can see from the diagram, the seventh nerve in the lower one, the seventh nerve and the fifth is just above it, and the sixth is medial most nerve. So our lesion is over here. The CP angle tumor is over there, and if you correlate with the neuroanatomy, where the seventh nerve lies over there, and during the maneuver, neurosurgical maneuver, it is likely that 6 and 7s were damaged. And when 6th nerve comes out of the pons, it has two parts: the motor nerve, which supplies the facial muscles, and it has a nervus intermedius, which contains the secremotor fiber to the lacrimal and also to the submandibular sublingual glands. So because any lesion, any compression of the seventh nerve at the CP angle, or when it runs into the middle ear, in the pittus part of the temporal bone, where it contains the secremotor fiber for the lacrimal, is damaged, it results into the damage to the parasympathetic innervation of the lacrimal nerve, which comes to the seventh nerve from the superior salivary nucleus, then to the seventh nervus intermedius, then geniculate ganglion. At the geniculate ganglion, these fibers left the main nerve, and they run into the gator petrosal nerve, and this gator petrosal nerve runs in the floor of the middle cranial fossa, and then it comes out to the foramen lacerum, and the fibers, they synapse in the sphenopalatine ganglion, and then to the zygomatic branch of the maxillary nerve, it supplies the parasympathetic fibers to the lacrimal. So this test will help us in differentiating whether it's a Bell's palsy, which is because of the involvement of 7 when it comes out the it comes out from this foramen and stenohyoid foramen. It comes out from that foramen. So the secretomotor fiber, they leave behind leave before the nerve comes out from this foramen. Hence, it's not involved, and you won't get any dryness of the eye. On the contrary, because the seventh nerve involvement is there is a more lacrimation. So any involvement of seventh nerve in the CP angle or in the pittus part or temporal lobe or in the middle ear can result into the dryness of the eyes because of the involvement of this secretomotor fiber. When this nerve will regenerate, as you know, any compressive lesion, there's a demyelination, then the remyelination. When the nerve will regenerate, which may take sometimes these fibers, which are supposed to go to the submandibular sublingual gland to the corona tympani, they get misdirected and they go into the gator pectoral nerve and supply to the lacrimal, which results into crocodile tear. This is the last case, which is about a 60-year-old person, man who was non-diabetic, non-hypertensive. When he came to us, he had a deviation of his right eye. He was unable to deviate his right eye laterally. That means he had a difficulty in abducting his right eye for last 3 weeks. Along with that, he had a very severe pain, very intractable pain in the right eye and a double vision. So when we examined, the visual acuity was subnormal in that eye, while in the left eye it was perfectly normal. He had a marked abduction restriction. He was not able to move his right eye beyond the midline. But if you can see, with so much of abduction restriction, there was very little bit of esotropia, while mostly in about 25% diopter, while the left eye was perfectly, and there was no proptosis in that eye. So my resident make a diagnosis of sixth nerve palsy. So when I examined, what I found, if there is so much of sixth nerve palsy that the eye was unable to move beyond the midline, there should be the adduction of this eye, or there was a marked esotropia which was not there. And when I examined the adduction movement and the version movement, the restriction was equal. So both of these features are very much suggestive restrictive element as a limitation of abduction. Because if it had been a sixth nerve palsy, there would be a marked esotropia because the patient was not able to move eye beyond the midline. And secondly, the adduction should be better than version. So both the things were not there, so I thought it must be a restrictive type of limitation of the movement. There was a afferent pupillary defect in the right eye, but the rest of the examination was normal. As I thought it must be restrictive element because of the less esotropia and the equal limitation of abduction, induction and version. So I did the retropulsion of the globe. What I found, there was resistance over there. And the proptosis was not there in this patient because they have a lot of atrophy of the retrobulbar fat. We got the ultrasound done over there. What we found, there was a marked enlargement of lateral rectus muscle. It was heterogeneous echogenicity of the muscle was there. Considering the age of the patient, more than 60 years, with marked pain, with limitation of movement, enlargement of lateral rectus muscle, I thought it might be a metastasis in the lateral rectus muscle. So these are the causes of massive enlargement of extraocular muscles. The common is the thyroid ophthalmopathy. Then come metastasis, pseudotumor, myositis, or IgG4 related orbitopathy, or lymphoma, or amyloidosis, or following a trauma when there is a hematoma in the muscle. So in our case, looking at considering the age of the patient, resistance to retropulsion, enlargement of lateral rectus muscle, we thought it must be metastasis. When we got the MRI done, we found out there was a fusiform mass which was quite big in the size in the lateral rectus muscle, causing displacement of the optic nerve, which was responsible for subnormal vision, causing the compressive optic neuropathy with the subnormal vision in that eye. And the neuroradiologist also made the diagnosis of metastasis in the muscle, and the MRI shows the multiple mats in the cranial, in the brain also. So keeping that, we looked for the primary in this patient. The ultrasound abdomen was normal, but the CT chest showed was suggestive of bronchogenic carcinoma. So this is a case of bronchogenic carcinoma presenting as a metastasis in the lateral rectus muscle, presenting clinically as a marked restriction of abduction and a restrictive limitation of the movement. Thank you.
Thank you, ma'am, for that wonderful presentation. These were the cases which were out of box. You have to think out of box. So now just coming on to the second presentation, from nuclear, infranuclear to the supranuclear movement, Dr. Priyadarshini Mishra. She is a faculty at AIIMS Bhubaneswar. Now she would present her cases or the presentation.
Good morning all. I have no financial interest in this presentation. So as madam already pointed out, so we have an afferent system and an efferent system. The efferent system, what we usually clinically think of is nuclear and infranuclear, Madam has shown lots of interesting cases, how our diagnosis can be misinterpreted or how we can, so we all learn from our mistakes. So now I'll come to supranuclear part of that. So what is supranuclear? The higher centers that is controlling the ocular movement, okay, that is cerebral cortex, the part of cerebral cortex, frontal eye field, posterior parietal cortex, middle temporal and medial superior temporal, which middle temporal, the recognition movement. So these are mostly concerned. Then comes to our basal ganglia, the red one, basal ganglia, then superior colliculus, thalamus, cerebellum, and rest is brainstem centers. Mouse is not working. In brainstem structure, we have lots of centers that are primarily concerned with these ocular movements. One is interstitial nucleus of Cajal. Another is medial longitudinal fasciculus. I will come to this one by one. Mesencephalic reticular formation, as we can see all this structure one by one. This is the brainstem, midbrain pons medulla along with the cerebellum, and posterior commissure, rostral interstitial nucleus of medial longitudinal fasciculus. Paramedian pontine reticular formation, PPRF. First I am showing the short form so that in later talks we will deal with the short forms. Dorsolateral pontine nucleus, although it is not visible here, better seen in axial view. Then we have vestibular nuclei and nucleus prepositus hypoglossi. So we have 6 systems, usually 6 ocular fixation system, vestibulo-ocular, optokinetic, smooth pursuit and vergence. So what is the role of ocular fixation system? It fixates the eye, and although what we know, any neural structures, they become fatigue after any fixation, the signal went away. To avoid that, the eye has a microsaccadic refixation movement. Although this movement is not clinically appreciated, but there is microsaccadic refixation movements that continue to fixate this eye. If there is disorder in this infection, we can have nystagmus or we can have saccadic intrusion. If it is a slow movement, then it is nystagmus. If it is a rapid eye movement, then it will be saccadic intrusion. So after this ocular fixation, we will come to vestibulo-ocular system. When our head is rotated for a brief period, then we are focusing on a subject and we are moving our head for a brief period, then eye will be fixed to that object by this vestibular, because it is for a brief period. The structures concerned are labyrinth, it is a part of inner ear, and it contains this semicircular canal 3, anterior, superior and posterior, and auricular and saccule. Cranial nerve 8th and 6th are involved. Cerebellum that fine tunes this vestibular, and although the otolith. So what lesion can occurs to this lower pons and medulla? If affected by any lesion, they are going to affect this vestibular system. How we test that in clinical? We assess, that is a head impulse test. 20 degree we rotate the head suddenly, and we see how the eye is moving in opposite direction properly or not. That is head impulse test. Then we see whether there is any nystagmus or not. And also we want to know where there is skew. So what happens in nystagmus? There can be peripheral vestibular system and there can be central vestibular system. How will you differentiate? In central vestibular system, usually the nystagmus is a vertical or torsional one, and it is not suppressed by fixation. Whereas in peripheral vestibular lesion, it is usually the horizontal nystagmus, and that is increased in the first phase. I will show a video after this. And there will be abnormal head impulse test. What I told, rotate the head suddenly 20 degree and see how the moving is. If it is malfunctioning, that eye will not focus to that point. It will go to a point, then refixation saccades, sketch-up saccades will be there. And in peripheral system, there will be no skew deviation. So now what is skew deviation? It is a vertical misalignment of eye. Due to asymmetric otolithic input, it is a vertical asymmetry. So in what case clinical we see other vertical asymmetry? Fourth nerve palsy. So how we are going to differentiate these two? Fourth nerve palsy and third nerve skew. So what we know in fourth nerve palsy, supply superior oblique. So when it is there is a palsy, so it will be intorsion will not be there. That means eye will be extorted. But what happens in skew? The hypertrophic eye will be intorsion of the hypertrophic eye. This is the like this. If we tilt our head one side, the higher end will be come down hypertrophic and the lower side will be. This is all to maintain a fixation point. But in skew, this is the one differentiation point, and as it is vestibular mediated, so when the patient lie down in supine position, it will improve, the nystagmus will improve and vertical deviation will improve, but in fourth nerve palsy vertical deviation will not improve. So this is a peripheral vestibular nucleus peripheral nystitis. As I have pointed out, only to show you nystagmus, that is right beating nystagmus. Beating means rightwards more, the first point is towards right, and it is following the Alexander's law, that is it is increasing in direction of the speed, first component, that is Alexander's law. So what I just 1 minute I want to again refocus. What was that? Hints test, head impulse, nystagmus and testing for screw. If these are positive, all three, then usually this is a peripheral component. So no need to do MRI. The stroke and other dangerous disease are usually excluded, but all three you need to rule out. Then come to optokinetic system. Now I talked what for a brief period. Then when it is a sustained head rotation, either the object is moving or the head is sustained moving. Because vestibular apparatus, there are cilia. Cilia are deflected. It stimulates the eighth nerve, so it fades away within a short time. But optokinetic system, it maintains then. So what happens optokinetic system? It can be tested clinically with a drum, optokinetic nystagmus. When we move eye in one direction, there will be contraversive, involuntary, reflexive saccade. So this is optokinetic system. Now coming to the most common, that is clinically and very much tested in brain central neurological disorders, is the saccadic system. It can be volitional and can be reflexive. So there is a horizontal pathway and there is a vertical pathway. Why I am going to little bit this pathway? Because it is usually to understand, otherwise we can interpret the cases. So horizontal system, our frontal eye field is affected. Then we come to basal ganglia, and whenever frontal eye is affecting, it is stimulating the contralateral PPRF, which is a horizontal gaze coordinator. So this is the contralateral side. There are burst cell, and to inhibit that there are omnipose cells. So I will be moved to this direction, and again there will be a pulse component that will start, and there will be a hold component. That means it will keeps the object holding in that eccentric gaze. It is called pulse step, and to integrate this pulse step we have neural coordinator, integrator, that is nucleus prepositus hypoglossi. So this is our vertical system. Again just remember two names, that is rostral interstitial and nucleus, and this is also the pathway system. This vestibular and saccadic, they meet at one point. So this is saccadic system for a vertical saccade pathway. Here it is the rostral interstitial and the neural integratory interstitial nucleus of Cahal. Then little bit about what we clinically see the most, that is interneuron. What are interneuron? Between these two nucleus, they are the communicating neurons, that is called interneuron. One is PPRF, most common for ophthalmology point of view, and one is MLF. So PPRF is the horizontal gate sensor that is located ventral to. We can see PPRF is here. This is the sixth nerve, that is pons, and just near this is PPRF. So this is one interneuron, and usually when the sixth nerve and PPRF is commonly affected, so this will be along with the abduction palsy due to sixth nerve, there will also the gaze center to this side will be affected, single side. And what is MLF? As we can see, this is the band, this is MLF. What it communicating? This is sixth nerve, ipsilateral third nerve to contralateral sixth nerve. This is MLF. So what happens, why these interneurons are very important? Clinically, these are the cases that first come to ophthalmologist, not to neurologist. So we should know these cases very well. So this is one. So before in the diagram also I am telling what suppose this structure is affected MLF. So what will, this is third nerve is affecting. So this eye adduction will be restricted. Always MLF that side it will be NMF. Suppose it is right side, so right internuclear ophthalmoplegia it will be told. And left side whatever, the while abduction there will be nystagmus. So this side adduction will be restricted and this side there will be abducting nystagmus. We can see this from these cases. As we can see, this is a young male. Just keep looking at the eye, how it is reacting. Whenever we are testing the gaze, the left eye adduction is restricted. And note the right eye. The right eye abduction is complete, but look at the nystagmus, that is. So this abducting nystagmus will be there. So this is called internuclear ophthalmoplegia. And what happens if when we are, as I told, one side sixth nerve and PPRF will be affected, then abduction palsy and gaze both will go. What happens when one side MLF and one side PPRF both will go? Then that is called 1.5 syndrome. That means only one abduction will be left one eye will be totally frozen and other side will be adduction. So we can test clinically how volutional, we can ask the patient to look at 2 points rapidly and we can see what is the velocity, what is the accuracy, that is looking at the point accurately. If not, that is hypometric or hypermetric. Hypometric in senile age group may be normal, but hypermetric is never. So if it is hypermetric, patient will overshoot and then come back. So, and we can see is there any involuntary slackers. If saccadic pathway is already I have told, there will be saccadic intrusion. These are very high, rapid movements. So, latency, accuracy, conjugacy, all we clinically need for saccades. And as we know, whenever we are going to ICU patients, whenever there is a lesion in frontal eye field, it indicates the contralateral saccade will be initiated, but now it is not happening. So eye will be conjugated, deviate to that side. But if it is a seizure like irritating lesion, then that will be deviated to contralateral side. Then smooth pursuit, as we track a smooth object of interest, smooth pursuit is little bit less understood till now as a saccadic pathway, but most probably the M ganglion cells and the magnocellular layer of lateral geniculate body to that middle temporal area is mostly involved. And from that it will become to our dorsolateral pontine nuclei will be affected and vestibular and abducens will be. So it will be a smooth pursuit and tracking system. So last is the Vergen system. Vergens I will not go to detail. Convergence and divergence is basic part of strabismus workup. So Vergens and just to little bit convergence, one important is dorsal midbrain syndrome. All of you should know dorsal midbrain syndrome. It is a part of convergence insufficiency is the part of this syndrome. And there can also be sometimes divergence insufficiency. And gaze preference I have already told, irritating lesion, and sometimes eye due to can be tonic downward definition, and sometimes some drugs can cause side effects, and it is called oculogyric crisis. I am just finishing my talk. So this is last two video I am just showing. As we can see, this is not a complete assessment, but here we can see this lesion is here in brainstem. So if you are seeing any brainstem lesion, try to record carefully what is that movement is being produced. Sometimes it may not give you a complete picture. dorsal midbrain syndrome, it is a incomplete one. But always try to look for that what is the lesion, so it will point out where the, this is also another horizontal gaze palsy. You can see there is a lesion, small lesion, these are very small lesions in brainstem.
फॉलो करते जाइए, हम वाला ले ले.
This by Kumudini madam, this photo and video Kumudini madam has taken. As you can see, this is a horizontal gaze palsy. So thank you all of you. Hope this talk will just create interest among you to little bit about the supranuclear pathway. Okay, thank you all of you.
So now coming on from the complex cases, I would just go on for the some basics of neuroimaging. So what are the common clinical conditions? I would be just dealing with how to read an MRI, how to read an CT, and how to identify whether it is a CT or MRI, and how to order and how to interpret some basic things. So common clinical conditions when a patient comes to you with a vision loss, maybe bitemporal hemianopia, that may be the finding, or some junctional scotoma or some homonymous hemianopia, that means now the time for the neuroimaging. Anisocoria and ptosis. Then comes your proptosis. It can be because of the thyroid eye disease or any space occupying lesion that is involving the orbit or some metastasis, as the madam has shown in one cases of that your lateral rectus muscle. So here comes the role of the imaging, that too not only in the orbit, that too in the brain also. And diplopia or ophthalmoplegia, as Dr. Priya and madam has shown, supranuclear, internuclear ophthalmoplegia, some gaze palsies, definitely the neuroimaging is the choice. Then comes oscillopsia, the nystagmus as already has been shown, and importantly as an ophthalmologist, for you daily you are encountering the patients of papilledema. So now you have to think on whether it is a disc edema or papilledema. If it is a papilledema, so now you have to go for the imaging. And what imaging? I will just put one case and just show you. So the chronology, it will go like a little bit brush for the PGs and for the general ophthalmologists of the brain and the orbit anatomy, some basics of CT and MRI in relation to the orbit and brain, and interpreting the stain and how to start scans and how to and what to order, and little bit one or two common clinical condition and their imaging patterns. So this is the orbit, as you can see very well over here, the orientation of the orbit, the medial wall parallel, and these the lateral wall making an angle of 90 degree in the axial plane. And more importantly, you can see very well over here, this is the medial orbital wall. The optic nerve is it is at an angle of round about 20 to 23 degree with the medial orbital wall. It is very important to know this, because when you are ordering what to order, I will just show you in the next few slides. So this is an axial CT, as we come on to later on, and these are the certain paranasal sinuses which are around the orbit and which are very important for you to know to order the imaging. As you can see anteriorly, if I cut a section from here, you can see these are the three sinuses, the frontal, the ethmoid, and the maxillary sinus. Very well you can see in this coronal section. This is the maxillary, frontal, and the ethmoid sinus. And when you just cut a section from here posteriorly, so here is the sphenoid, you can see the sphenoid sinus. So now coming on to the skull base. What is the skull base? It is formed by, what is this? The sphenoid bone and the occipital bone. This is the clivus. So this mainly, this is very important because it is also forming the roof of the orbit. Now lateral wall of the orbit, importantly it is formed by the wing of the sphenoid. Over here you can see, and it is very much in contiguity with the middle, that your cranial fossa over here, and here is the lying the temporal lobe. So this is again a important thing to know about. Then your optic canal, you can see very well over here, this is the optic canal from the one side, as over here this is the optic canal, this is the optic canal. So it is again contiguous with the middle cranial fossa and your anterior cranial fossa. So any lesion over here would be affecting the optic nerve, and you have to know whether to order an imaging or not, seeing the condition of the patient. And one more important thing, when you cut a section from here, so the muscle will be, this muscle would be okay exactly perpendicular, but the lateral rectus would be, if you cut from here, that means this is an coronal section. So there are what you call is quasi-sagittal and quasi-coronal, that I would just come later on. And canals and fissure, you know, this is the supraorbital fissure, again it is in contiguity with the middle cranial fossa, and this is your paracellar region. This is the sella and the paracellar region. You can see over here, this is the cella and the paracellar, the optic nerve are coming, this is the ICA. These are all that in the cavernous sinus lying. This is the cella and the paracellar region. So you have to order while just encountering your third nerve, fourth nerve or whatever diplopia, you have to order this cella, paracellar, cornal, axial, 2 mm section with and without contrast. You have to order. So now this is the floor of the orbit. The only important thing is this is the infraorbital fissure lying over here. You can see seeing from above and from a sagittal section. So this is the infraorbital fissure connecting with the pterygopalatine fossa and the infratemporal and the temporal fossa. So this is again the maxillary sinus. You can see this is a quasi-sagittal section. Now, seeing upon these three films, now you have to think how to identify and how to read. So CT scan, I'm just going for the indication, then I would just come on how to read and how to identify. So CT scan, most versatile, bony details. If you want to know the bony details, the calcification, some temporal or spatial resolution, then it is the imaging of the choice in a hurry, because the imaging time is very less. But the downside is 100 times more of the single X-ray, that the radiation you are exposing. So be careful in the pediatric patient. Nowadays there are machines which are producing less radiation for the pediatric also, the newer machines. But the other important thing is the beam hardening artifacts. What is that? When the patient is having any metallic implant or any metallic foreign body or dental implant, then what would be seen? These are the radiating. You can see over here spirally or the radiating. These are the black and the white shadows. This is the whatever that foreign body is. So these are called the beam hardening artifacts. So now coming on to the MRI, it is a choice. Nowadays it is the only choice which you are having, apart from 1 or 2 indications for the CT scan and for the soft tissue, for the orbitocranial junction. Why? Orbitocranial junction is this, lot of bones are there, the sphenoid and other bone. So if you want to know about the soft tissues, then you have to order the MRI. Imaging time is longer, definitely must screen for metallic foreign body. If there is patient comes to you that with a foreign body and then there is an immediate history, then never go for a MRI if that is a metallic foreign body, because if it is in orbit it can dislodge, and if it is in brain definitely it can do much more harm than your imaging, getting the imaging done. The cardiac pacemaker and that your the foreign body. In fact, now for the cardiac pacemaker also, because nowadays the 3 Tesla MRI are in more vogue, but still with 1.5 Tesla and with little more less ferromagnetic radiation, you can in fact nowadays with the softwares you can just do the MRI in the patient with the pacemaker also. So now as in for the orbit, as MRI for the preferential choice, all these are the indication. I'm not going to just go again for that. And for the CT again, the orbital trauma, foreign body calcification, osseous. And one more thing, when you want to know the bony destruction, is the bony destruction, how you would come to know, because the MRI would not show the bone. So whenever there is a tumor in the brain and you want to know whether the thinning of the bone is there, then you have to order the CT scan. Again, for this your brain imaging, when you are seeing a patient of only ophthalmics, that your ocular concern, and you want to order imaging, so these are the indications you have to think in your mind: the demyelination, tuberculosis, TBM, NCC, neurocysticercosis, anemic core, you must be knowing about in the COVID era, and cranial nerve lesions. Then the detection of foreign wood body, your wood foreign body, because the that would be missed on your CT scan also. And pathology near, as I showed you, and this is how to that you know about any head injury, you go for that CT scan, and all other I have already illustrated. Now this is the gantry of the CT scan. Little bit about how you must have heard of about 64 slice, 128 slice. What is that? 64, 128. This is the gantry. These are the detectors. This is the patient lying over here. So these are the detectors. This is the patient lying on a couch, and these are the detectors. Earlier they were single. Your radiation was given, and the time taken for the CT scan, I'm talking about in 90s, early 90s or late 90s, and single detectors was there, so lot of radiation was the patient has to be exposed. But nowadays these are the detectors, number of detectors, 64, 124, 128, either they are lined, they are stacked in rows. So according to the number of detectors, and maybe 64 or 128, or these 64 or 128 might also be having sub detectors within them. So these are the number of detectors. So according to them, this is 64 or 128 slice. And now what is doing, in spite of instead of giving these single radiation, spiral radiations are now given, so that not on a single 1 millimeter of the tissue is left for the radiation that is being exposed, and you can get every detail of the area what you have exposed. So CT versus MRI. Now how to know? The bone is bright in CT scan, you can see over here, and the bone is hyper dark in the MRI. You can see over here, this is the bone, this black. And no, you know what is this? This white is the bone marrow in the bone in MRI. So bone is black on MRI, but the marrow is little bit white. And what is this whiteness is? This whiteness is the scalp, that is the tissue, soft tissue. This is bright. So interpreting the scan. Now the patient detail, it would be there, all the annotation, they would be showing the patient details. And now this right side, lower side, again there are annotations. These would be showing what this MRI is, whether it is a T1, T2, fat set, everything would be written over here. So how would you come to know? With this is the right and left, this is right, because without these annotations you won't be able to know whether this is right or left. Many times the experienced radiologist can get confused, definitely. So the right, left, and this is an MR venogram. You can see this is left written. And one more thing, whether you are seeing it from anteriorly, this venogram, or from posteriorly, it is also written over here. This is the P, that means you are seeing it from posteriorly. So these are the image plane. I am not going into detail. These are the axial, these are the coronal, I have already shown you, these are the sagittal. Now one more thing about the bone window, window. This is the soft tissue. You can see this is density, isodense, and this is the bone. So this is the bone, bright, and furthermore bright, and you are just attenuating the soft tissue, then you call it as bone window on the right side. So intravenous contrast, why to give, which one to give, or this all dependent upon the radiologist. But you should know as an ophthalmologist when you are ordering, because they serve to improve the sensitivity and the specificity of the diagnostic images by the altering the intrinsic properties of the tissue. What we are just using is the intrinsic property of the tissue in the CT scan, and that too in the MRI. So these contrast, they are just absorbing into those tissues, and they are emitting the radiation or whatever they are doing. Now you are just making the sensitivity and the specificity is more. Better delineates the structure due to differential contrast uptake, because the lesions, that they can be inflammatory, there can be tumor. So difference in their uptake definitely leads to the diagnosis. And in cases of trauma fractures, I don't think that you have to write the with MRI with and without contrast, only with MRI or with CT scan plain. Now contrast, iodinated. Nowadays iodinated are used because why iodinated? Because iodine is the substance which is more hyperdense on the imaging, and nowadays we are using non-ionic and isoosmolar, so there is minimal reaction and metabolic alterations. And in gadolinium, what CT scan we are using iodinated, and in MR we are using gadolinium. This is water soluble, paramagnetic, ionic, and non-ionic. So the only concern is nephrogenic systemic fibrosis. That is the reason always when you are sending the patient for MRI with contrast, always just get your creatinine or KFT done. So now contrast and non-contrast, how would you know? This is, can you see over here, this is written, sorry, over here. Yeah. So this is homogeneous. It can be homogeneous because of the aneurysm or varices. It can be heterogeneous because of the tumor, hemangioma, rhabdomyosarcoma, and inflammatory. So in those cases, it can be heterogeneous. So what I was showing you, this is the image 9 and this is the image 6. 6 plus C. If you are not able to whether this is contrast or not contrast, see the annotation plus C would be written. One more thing I am just giving you, this is your basilar artery. So contrast would be filled in the vessels. So this is the basilar artery in front of your midbrain. So this is what is your contrast. The vessel is seen. So contrast again, very well you can see this is the contrast taken up by the glioma, and this is again you can see the brightness. These are the brightness, these are the brightness, these are the uptake by vessels. One more thing over here you can see plus C. This is what I just wanted to show. This is plus C. So these are basic sequences: T1 T2 weighted, T2 fat sat, and T1 fat sat. That means the fat is saturated and post contrast. Thin section I'm not going into detail now. These compare this. This is as you know, white is fluid. White fluid is what? White is what? Fluid is white on T2. But this is T1. This is what? Black. Fluid is black. But now one more thing. This is your gray matter. This is white on T1. So apart from seeing the vitreous and the CSF, you can also see this is the gray matter. Outer is white matter. Outer is the gray matter. Inner is the white matter, and it is hyper intense. Now again you can compare T2 and T1 images. I'm going into this one, T2 and T1 now. This is white, this is black. And the muscles, as you can see, they can be iso or hyper intense or intermediate intense. Fluid is bright. Signal void. What is signal void? Signal void is where there is no signal. When there is an air or when the vessels are there. So the blood would be high flowing. So it would not take any that your radiation, or it would not emit anything. So the flow void, they are called flow void. So fat set, this is sagittal. Now one more thing, you can see these two images, again T2 and this is also T2, but what is happening, the fat is bright, but over here this brightness has gone, so this is fat set. So T2 fat set, to better delineate the lesion, T1 fat set and T2 fat set. So you have to, in orbit, you have to suppress the fat. You can see very well over here, this is again and this is now. The fat is saturated. The extraocular muscles, now they are becoming more prominent. Now this area, this retro-orbital area or the ocular area, you can see this is the orbital area, the fat is not saturated. Here the fat is saturated. So very well the extraocular muscles are delineated. Other sequences are, you can see this is a flare sequence, fluid, attenuation, inversion recovery. You can see this is the T2, this is again T2, but the fluid is attenuated. This is white, this is black. Why it is done? To know the demyelination in and around the ventricle. So flare mostly are done in demyelinating cases when you are encountering optic nerve or you are just suspecting multiple sclerosis. This is one maximum intensity projection. One sequence madam has shown a third nerve. Nerves are very difficult to visualize. So what? These are certain sequences. One BFEE, CRIS, and this is maximum intensity projection. You can see the fourth nerve and over here the sixth nerve. This is ascending on the clivus, which I told you, the base of the skull, ascending on the clivus. So cavernous hemangioma, one is dynamic MRI. You can see very well over here the filling of the the contrast. So definitely you can see on the console dynamic MRI, and you can just later on put this on the films also. So this last case and last slide, my just another sequence what you have to know about is intense headache, 28-year female, restriction, diplopia, decreased vision, left eye. So seizure episode की history नहीं थी, no any other neurological deficit. The only positive one that she was an obese female with a history of recent weight gain. Vision was 624 in the left eye. There was a grade 1 RAPD, bilateral disc edema. I will show you that means not disc edema, it was papilledema and generalized constriction of field. This is the restriction of the movement. This is the papilledema, as you can see, bilateral, and this is the restriction of the field. Now the imaging of choice. What would you order? This is not plain MRI. MRI either with contrast, with MRV with contrast. Why? You can see very well over here. This is MRV, which I showed you. We are seeing it from posteriorly, and this is the superior sagittal sinus. The pictorial representation is over here. This is the transverse sinus. This is the transverse sinus, and this is the junction of the sigmoid and the transverse sinus. So over here you can see this is stenosed. So MRV with contrast in any case, a female middle-aged coming to you with papilledema, so definitely you order MRV with contrast importantly. So patient was investigated for coagulopathy and anticardiolipin syndrome was there. So MRV I have already shown you. This is the optic nerve glioma. Optic nerve glioma on the MR you can see very well over here. This is your optic nerve. This is your optic nerve. This is again, which sequence is this? This is fat sat T2 sequence, coronal fat sat T2 sequence. So fat over here, fat is not saturated, and now again you can see post contrast. This is taking up the contrast. So optic nerve sheath meningioma, I think the time is gone because the other speaker have to just commence. So now I'm just leaving all this, and take home message is ophthalmology should be aware of specific clinical indication of CT MRI in neuro-ophthalmology and be prepared to recognize the distinctive radiological signs for each clinical entity. And one more thing, now the resident would not just keep the film away, they would just look upon that report. Please just pick the film, try to identify each and everything. Thank you.
So thank you, sir, for a very wonderful presentation. Before starting the presentation, I would like to thank my mentors, that Professor Dr. Kumudini Sharma ma'am and Professor Dr. Vikas Kanodia sir, under whom I have done my senior residency and under whom I have learned some basic knowledge about the neuro-ophthalmology. Thank you, sir. Thank you, sir and ma'am. So my topic of discussion is case-based discussion. It is the last topic in this session. So as ma'am and sir both have reinforced that there is very large importance of imaging, both imaging and both interpretation of the imaging. So it plays a very pivotal role in diagnosing the case, and beside this, a very careful clinical history. So on this note, I start the presentation. So my first case is a 14-year-old boy which was sent from neurosurgery for pre-operative neuro-ophthalmic evaluation with diagnosis of cavernous sinus hemangioma. On history, he complained of double vision for 2 months, and on a very careful clinical history, he gave a history of a boil at left angle of mouth with cellulitis on left side of the face, which was 4 months back. On examination, patient had right esotropia. The vision was normal in both the eyes. Ocular motility was, there was abduction restriction in the right. Pupil was normal size and normal reaction in both the eyes. Fundus was normal. Field was within normal limits. And rest of the systemic examination was normal. MRI report done outside. There was a cellular mass, as you can see here, with contrast enhancement and extension in right cavernous sinus with internal carotid artery being pushed peripherally. So the diagnosis of cavernous hemangioma was made. But when the MRI was re-evaluated, we found that on T2 weighted MRI, it was a sac-like outpouching. If anyone has seen the cavernous hemangioma MRI, there is a homogeneous contrast enhancement. Here you can see that it is not homogeneous contrast enhancement. What it is there is a peripheral hyperintense signal. This is peripheral hyperintense signal, then hypointense signal, and then again hyperintense signal, which was suggestive of a turbulent flow in the sac. So post-contrast MRI also shows intense enhancement suggestive of mycotic aneurysm of right cavernous sinus of internal carotid artery. DSA also, digital subtraction angiography, also confirmed the same. Blood culture was negative, but on the hemogram there was increased leukocytosis, increased ESR and increased CRP, which pointed towards a infective pathology. Patient underwent parent vessel occlusion of the right internal carotid artery with vascular plug of vitreous and upper cervical part. On post-occlusion, there was no flow, and on follow-up, right 6 nerve palsy is improving. So it was a very out-of-the-box case, as mycotic aneurysm, we all know, is a dilatation of the artery due to damage of the vessel wall by an infection. It is also called as infected aneurysm. This aneurysm is very dangerous because it has a high tendency to rupture, and a very high index of suspicion is required to make the diagnosis. So what was the catch in this? The MRI finding of the turbulent flow in the lesion helped in making the diagnosis of mycotic aneurysm. And mycotic aneurysm is also a disease of the elderly. It mainly presents around 65 years of age. There may be history of intravenous drug abuse. There may be a history of immunocompromised state or a history of endocarditis. And very lastly, the cerebral arteries are involved. Most commonly, femoral arteries, aorta and splanchnic arteries are involved. So it was a very atypical case, which was diagnosed on high index of suspicion and a good radiological evaluation. Now coming to the case 2, a 33-year-old male patient presented to a local doctor with complaints of to a local ophthalmologist with complaints of sudden onset diminution of vision and mild pain in right eye for 2 days. His vision was PL positive in right eye and 6/9 in left eye. He was diagnosed as a case of retrobulbar neuritis and was started on injection methylprednisolone followed by oral steroids along with oral multivitamins. But patient was not very symptomatically better, so he consulted our neuro-ophthalmology department. On examination here, the vision has improved to 6/18, and in left eye, the vision was 6/9. But we found other findings also. There was no history of nausea, vomiting, headache, diplopia, or any other neurological complaints. Pupil in right eye show RAPD with sluggish reaction to light. Color vision was impaired in right eye, whereas in left eye it was normal. Fundus examination revealed pallor in right eye, but there was also temporal pallor present in left eye also. Perimetry here revealed bitemporal hemianopia with central scotoma in right eye. VP showed normal latency in both eyes. MRI on initial examination revealed findings suggestive of hemorrhage in suprasellar region on right, tracking along right optic tract at an institute. As can be seen in this picture, there is hyperintensity in suprasellar region on right and along right optic tract suggestive of this. It is suggestive of hemorrhage in suprasellar region and along right optic tract fibers. So, when the follow-up MRI at our institute showed minimal patchy enhancement in a small space-occupying lesion in relation to optic chiasma on right with partially resolved bleed, suggestive of a cavernous angioma with bleed, which is also known as chiasmal apoplexy. Patient was referred to neurosurgery for surgical intervention. So this is the hemorrhage with the T2 images show heterointense lobulated lesion in the region of optic chiasma. This suprasellar region more towards right with peripheral T2 hyperintense rim. So it was a case of chiasmal apoplexy which was misdiagnosed as optic neuritis. Chiasmal apoplexy is a very uncommon clinical syndrome. It consists of a triad of abrupt frontal retrobulbar headache, abrupt visual loss, and chiasmal field defect. The source of hemorrhage is either a cavernous malformation or an AV malformation of the optic chiasma. So, not only this case, earlier also there have been cases which have been presented as misdiagnosed as optic neuritis, as in a study conducted by Peterson et al. 3 patients were misdiagnosed as optic neuritis patient. But after taking a brain CT, pituitary adenoma together with the formation of cyst was detected in patients. So the correct diagnosis, who had been incorrectly diagnosed as optic neuritis, was pituitary apoplexy. So if optic neuritis patient presents with bilateral presentation, if there is very profound loss of vision, if there is absence of pain prior to vision loss, together with atypical neurological findings, one should search for an alternative etiology. Thank you for your patient listening.
So we can have the discussion in the end if somebody has any question. We can have a discussion in the end if somebody has any question or anything they want to ask.
When we ask for MRI, for the indications you suggested, do we have to write T1, T2, or is that the radiologist?
No, radiologist would be deciding the factor what he is going to do, but the contrast and the sequences you want, and definitely the probable diagnosis, that should be there. Yeah, that would make him to understand which sequence to go. Because what we are just simply writing MRI brain, MRI orbit, but we have to write the diagnosis also, the differential diagnosis. In what line we are thinking on. If we give that, the radiologist always says, kindly write 1 or 2 findings and your probable diagnosis.
Because that will help them on which area of the brain they have to focus more. Yeah.
And for optic neuritis, we don't generally do an MRI or anything like that.
No, I think we should do just to rule out MS and prognosticate the visual outcome or the further course of the how it is a part of a MS or not. If there are demyelinating plaques are there periventricular or subcortical, and the dissemination in time and space is there, then we are very much sure this optic neuritis is a part of MS. So, or if MS is not at the time of presentation optic neuritis, then we can say this patient has a likely chance of developing MS future on.
Because later on you can just know, okay, what happened to this patient. So you would be having a baseline MRI. Patient comes to you again with the optic neuritis, maybe 5 to 6 years down the lane. So you can know that these features were not there, now they are there.
So, yeah. I think in every case of optic neuritis, one should
Yeah, one
get
should
the finer curves of the orbit with without contrast and the cranial also. Sometimes you can find the demyelination of the optic nerve also. Sometimes idiopathic optic neuritis, you have to differentiate is a part of NMO or it's a part of MOG, anti-MOG antibody. So it's important. Secondly, it's very important to emphasize it there to the ophthalmologist that there any patient with where you find the visual loss is there subacute or something, it's a progressively patient losing vision, but the fundus is perfectly normal, the disc is normal, you still get the MRI. People I've seen giving glasses to the patient. Do the pupil examination. I don't think people in hurried OPD with so many patients, they don't do. And even the quick confrontation test should be done. So some of the cases we have seen the patient was given the glasses and didn't ask for the neuroimaging. When the patient came to us, then we found a big pituitary adenoma. Because in pituitary adenoma, it is descending type of optic atrophy. It will not show on the disc. This would be normal. It will take some time to manifest on the disc. So the pupil and the confrontation would be very important.
Also, visual acuity would be affected.
But still, the subnormal visual acuity, which is continuously deteriorating, but people, they don't suspect. I don't think so. They don't suspect. They keep on correcting with the glasses, which doesn't get corrected with the glasses. Very important.
Be affected here.
They don't do. I have seen so many patients.
Affected color vision.
Compressive lesion may not be. It's a very much affected, demyelinating.
Madam, you are asking anterior ischemic optic neuropathy.
Do I have to do an MRI for that?
No, anti-ischemic optic neuropathy you don't have to, because it's a clear-cut sudden loss of vision when the patient gets up and would have a systemic disorder like diabetes, hypertension, dyslipidemia. So you will know there is even a segmental pallor with a disc edema would be there. Sometime you may get an overlapping picture with demyelination and anti-ischemic optic neuropathy. Sometimes it is difficult to make out. Yeah, one atypical type of cases you should do it. So proper pupil examination and confrontation field, very important. The patient progressive loss of vision with headache. If the patient is a progressive visual loss with headache, beside the ocular causes, there are more important the cranial cause to rule out. You can say. Okay, we can. Now, as there is no more questions, so we end up to our session, and the next session would be. किसी से कह देते हैं, इनसे कह देते हैं, ये लोग कर देंगे.
I can take it for you. It was an excellent session. I really enjoyed it.
Thank you. Thank you very much.
Do you want me to take a picture?
Yeah, you would be taking.
अच्छा, okay.
Sana kaya sarili mo sa namin, hindi na po.